Good evening, Dr. Venu. Welcome to this webinar live series, which we are on behalf of Yashoda Hospitals. I would like to welcome you for this webinar where it's been live streamed and it has been viewed across the world by many people. It's my privilege to introduce my close friend, Dr. Venugopalan PP, who is a very dear friend since 15 years, who is in emergency medicine stalwart. He started one of the earliest academics in emergency medicine with George Washington University and also with the National Board of Examinations. He is the group director for emergency medicine and the lead consultant in Aster DM Healthcare. There is much fame. He has many publications. His interest in pre-hospital service is enormous. With this one, he had started the Angels Network, which has benefited across many public in Kerala, and it had network in many places. The paramedics who have come out of him are working throughout the world. The residents who have come out of him are working throughout the world. With these few words, I would like to welcome you to carry on with the topic that is the chest X-ray and PXR, a systematic approach. I'm sure that the residents who are viewing will be benefited from this. Thank you, Dr. Venu. Please go ahead.
Thank you, Yashoda Hospital and Srinath, my friend, for the nice intro. And I'm without anything, I'm just getting to the topic. I thought when asking to do a presentation for this forum, then I thought like what I would speak. Then I thought like something I would speak which is beneficial for particularly the residents who are managing trauma. So that is a reason why I just taken this is I'm not any hi-fi things, just we will a very basic thing, but these basic things will help you in your day-to-day practice. So like in trauma, when you are approaching a trauma patient present to you, your approach would be like a primary survey and a secondary survey. And in primary survey, secondary survey approach, like in primary survey, we will do that ABCDE approach. That is the ATLS approach. And during the ATLS, and patient may present with multiple issues. Maybe patient may with a head injury, neck injury, and spine injury, injury, chest injury, abdomen, multiple things. We don't know what is it. And maybe when we are approaching, we may be confused with what all the imaging should be done. Here, I'm very high focusing and part of an adjuvant in the primary survey, we will do only 2 X-rays in primary survey. Like the primary survey, which is focusing on the physiology and also which correcting the derangement and stabilizing the patient. And these contests, the 2 X-rays, which is vital, and that will help to save the life. And that will help us to stabilize the patient. This is 2 X-ray. One is chest X-ray and other one is pelvic X-ray. And we'll go through that. How once you got the X-ray, how will you interpret and how will you systematically approach and reading these X-rays? And here, like just you go to this is actually what whatever is given is taken from ATLS textbook. When you get previously, when in the 2009 and all, when we are doing the ATLS, it was just an ABCD approach. Now this is converted in the recent in the 10th edition onwards. The X-ray reading approach is DR DRS ABCD ABCDE approach. So what is this? This is a mnemonic you can easily decode and you can approach accordingly. The D is once you got the X-ray with you, you just see like there are like the X-ray should not you should not read someone else's X-ray, and you should also know whether the X-ray film is what type of film, and it's a time. So this kind of misplaced and misinterpreted X-rays are very common. So that is the reason why I start with a day. Make sure that this is belonging to the which patients, and also what the demographics of that patient, and what type of film is this. Usually in trauma, it is an AP film, and also when it was taken and what time it was taken. Suppose someone with a chest injury or a chest injury, you may take an X-ray before an intercostal tube, sometimes after putting an. So the time, date, everything is important. So first of all, make sure that before interpreting, go through these details, include the name, demographic, type of film, date, and time. Then you go for the R. R is regarding the quality of the image that you can decode with the RIP, right? This is include, how the film, how the rotation of the film. I is to look at whether it is an inspiratory film. If it is an inspiratory film, 5-6 rib anterior to mid clavicular line, or it is the ribs are 8 and 10 ribs above the diaphragm, or it is in a poor inspiration, or it is in a hyper all these information you will get by looking at R right. Then P is the picture. Can you see the entire lung field in a field adequately, and how the exposure, whether it is an overexposed or underexposed. This much things you have to look into in R. That is, you think about by RIPE. Then DRS, yes, is you again look into the soft tissues and bones, any fractures, any kind of hematoma, any foreign body, or in the any subcutaneous emphysema, etc. And then, yes, classically we will go to that ABCD, rest of the ABCD. You follow, you just try first. You try to visualize how the trachea, how the X-ray, this trachea is central, deviate to right or left, and as you progress to the mediastinum, whether it is normal or it is widened. And coming to the breathing, you go to the lung fields, go to every areas. You can divide the lung into 3 zones. Both it can be the upper, middle, and the lower zones, and compare these zones between the right. Compare the zone between right and left, and you specifically look for pneumothorax, specifically look for consolidation or the pulmonary contusions, and also look for any lesions. And coming to the C, in circulation, you look into the heart size, the borders, position of the borders, and also look at the aortic strip. And coming to the D, like that the diaphragm is the shape, and particularly you look at the 2 angles, the cardiophrenic angle and other costophrenic angle, and also look at the gastric bubbles, and also look at the subdiaphragmatic area for any air. And finally, for the E is you look at the endotracheal tube. If it is there, what is the position? That is the extras. That is the endotracheal tube. Look at the central venous. If it is a central line, whether it is in position. Look at the NG tube. This is in the position, or is this in the again? You look at the electrodes, chest tube, any other pacemakers. All these. This is a composite way you can look into the you look into the X-rays. So now we will see that a few of the X-rays, how this look like. Here you just look into the X-ray, and here same. Again, the data, it is not, if there is some data, is you have to see like that. And overall, when you are looking at inspiration, film is adequate, exposure is adequate. And it is it is all the ribs are seen, field is adequate, like that. Again, the soft tissue when looking at, nothing is seen. Look at the bones, there is no fractures. Now you coming to the airway, here you see, can see the chest, in the trachea is central, and there is no rotation. And also you can go through the, you can look into the lung fields on either side, in upper zone, mid zone, and lower zone, all are equal, and it is seem to be normal. And coming to the Z, the cardiac borders, the mediastinum, cardiac shield, this all seen normal. And then coming to the ankle, costophrenic angle, and cardiophrenic angle on either side is normal, not obliterated. No gas under diaphragm. There is, it's all like it's a normal X-ray. If you approach this way, sometimes when we are reading the X-ray, we will find some findings. Immediately we will shift it to know, we will maybe fix it on that. But the consequences of this kind of, if you are not reading in a systematic way, what will happen is sometimes you may miss it, few findings. Okay, so this is about this see what is in the next slide. Yes. So what is seen these X-rays? Here, any comment? Anything is there? Anyone? Okay, we'll do that systematic approach. You go to the identity, exposure, the rotation, it is all okay. And when you are looking here, what all things you can see? So look at the airway. Airway is slightly shifted to right side. And there are lung fields when you are comparing. This is not much. You can, this is just, you can see like maybe the film when you look at the rotation, the distance from the spine to the medial. And this is because slightly rotated. Maybe there is a reason why, because it is showing it is shifted to right. And extras, there are, you can see few of the leads are seen here. Now you are coming to this X-ray. This is a person brought following road traffic accident, and his left side the sounds are less, saturation is dipping, and then they are intubate. Now you are looking here, see what all the things you can see. A systematic approach, that identity, the position, rotation, rotated, and then you coming to the airway. You can see there. You can see tracheal tube is inside, and can you see like it is not only a tracheal tube is inside. You see like how the position of the tube. The position of the tube is bit low. That means it is a endobronchial intubation. Maybe you can see, look at the breathing side, entire left side is hazy. Maybe the entire left side lung is collapsed. And this is due to an endobronchial intubation. That is the reason by the other side, the lung is collapsed. And also you can see leads and other things. Maybe if you withdraw and start a reventilation, maybe it will going to get corrected, or it can be due to a lung contusion on the left side also. But generally, with this film, we will look at it can be a right endobronchial intubation. Yes, this is another X-ray of the chest. It is a trauma patient, and looking at the quality, it is okay, reasonable, but mediastinum and you cannot comment much in the upper part. Maybe look like a small widening, but more than that, when coming to the lung field, you can see the like a homogeneous opacity in the upper and the middle zone, and also you can see here the lung on the right side is collapsed totally, and also you can see that hemothorax on the right side, and you can see like the lung is in diaphragm is pushed down on the right side, and the left side cardiophrenic angle you cannot command much. So maybe this patient is having pneumothorax, which collapse. Which, again, there you can see there is a chest tube here, but it is placed. Okay. So these are the finding on this this X-rays. Now we have another X-rays here. Here you can, rather than going to, I'll just go to the important findings like that. In the airway there is a endotracheal tube is in place, and you can see that on the lung field there is a haziness in the upper and middle zone, maybe due to a pulmonary condition. When you are closely looking into, you can see that rib fractures, that is first, second, third, like that. And you just go to the extra in the subcutaneous area, you can see emphysema. You can also see there is a chest tube is in place. Maybe there is a hemothorax as well here on the left side. These are the finding you can see. Here there is another X-rays. When you are looking here, so there is a tube in the trachea, and you look at the mediastinum. This mediastinum is widened, maybe an aortic rupture, and they're finding here a widened mediastinum, maybe a aortic rupture. And here it is another case of trauma case. Here, when you are looking, almost other things are normal. When you are looking into the diaphragm height, the left side diaphragm is high, and it is almost is in the thorax, and it's diaphragmatic hernia or the diaphragmatic rupture, which may lead to the herniation of the stomach content into the diaphragm. And here, one important intervention you have to immediately is that to do that nasogastric intubation. Maybe it will help to deflate, and rest of the thing will for the destination management. So these are about the X-ray chest. Now we are coming to the X-ray interpretation. And the most of the finding that we discussed in the X-ray chest, that will, if you are not addressed, that will kill your patient. That is the reason why it is coming under in the primary survey. And most of these issues you have to intervene by yourself. You can put it like a chest tube, or that if it is a wound, put it like the three level closed dressing, like that. All that life-saving intervention should be happen there. Now coming to the pelvic X-ray. Pelvic X-rays, starting the pelvic X-rays. So what do you want to do? Like what view are usually taken in pelvic X-rays? Routinely, the pelvic X-rays are taken AP view, anterior posterior projection, and it is 94% of the cases will do that way. And it will give you the correct diagnosis and can be, and times when the fracture is noted, very special. Sometimes you may need a special views like inlet, outlet view, or an oblique view. Standard, we will do like 94% of the majority of the cases, we will do an AP view. So about the pelvics, some understanding about a few words about that mechanism of injury. Usually there are the 4 types of mechanism of injury which leads to the pelvic trauma. That include like the anterior posterior compression, and this anterior posterior compression usually leads to that open book fractures, and lateral sometimes may cause it's a lateral compression. This will cause horizontal fractures through, particularly in the ipsilateral pubic symphysis. Sometimes momentary medical displacement of the hemipelvis, that can be usually. Then other one is a vertical shear. Someone is fall from height. This will cause multiple fractures, which include acetabulum, even the neck of femur, even the foot. All this can happen in vertical shear. Even sometimes spinal fractures can occur. You may get a 25% of less cases, you can get a complex pattern where the pelvis is exposed to 2 or more folds as mentioned above, and it will cause a combination of injuries which result in a complex radiology. Now, when approaching to the pelvic X-rays, here, there are now there are 4 or 5 boards. So you have some anatomical idea when we are approaching pelvic X-ray, here we have there are important bones like ischium, that is a hemipelvis, which goes for right and left hemipelvis, and some of the, then the sacroiliac joint, sacrum in the behind, then the pelvic ring, then the obturator foramen, and also you can see the pubic symphysis. And this all these area you have to examine in the X-ray in a systematic way. We'll move further. Here here also, when approaching the pelvis also, because we are the ATLS, and when we are managing trauma, every time we are looking into wherever you are reading the X-rays and image, we will follow that ABCD order. And the pelvis also, you can follow this ABCD order. Here the A is you look at the adequacy and alignment, and you look at all bones, the pelvic, that aperture, and look at the cartilages, then look at the diameters, and also you look at in the E, that is the extras like soft tissue tubes, any dye, hematoma, foreign body, etc. So in the A, you can look at an adequacy, particularly the A, you look at the adequacy, alignment, adequacy and alignment, and also you get the data, and also like view and how the exposure. So basically the adequacy and alignment has got, you have to collect the data about that picture, like how the exposure, what extent it is seen, and what kind of view it is, how the exposure. This much things you will see in this. Then, so when we look into what all the things we are looking in each area. In the A, as I explained, you can look at into adequacy and quality of film, and ensure that all of the pelvis is visible. And all of the pelvis visible means you have to see the entire ring of the ischium up to the at least the upper third of the femur. This much you have to see. And alignment, to assess the alignment, assess the to see the alignment, you must assess the borders of 3 circles, which is named the pelvic brim, as well as 2 foramina. And here You can see this is a pelvic X-ray. You can see here it is the alignment and exposure is adequate. And again, you see that you can see the picture from the pelvic, I mean the ischial bone to the at least like the upper third of the femur is seen. You can see all the bones. All things. This is apparently a normal. It is a normal X-ray. Because you can see the bone. You can see the all bones like ischium, then like the femur, pubis symphysis, sacrum, pelvic cavity, pelvic inlet, and two obturator foramen. So this you see like this much area. It is you have to at least like this much area. If then only you can see this picture is adequate. The next you can see for the alignment a few lines. One line, this is drawn like this on either side. See, this is what is called a Shenton's line. If this Shenton's line is disrupted, means there is fracture or dislocation all there. And also during the alignment, you also see few other lines. One is the ilioischial line. That is represent the posterior column, and also another line is iliopectineal line, that is represent the anterior column. Iliopectineal line, ischial line, and anterior line. And also you look at just screen out the acetabulum. So now we will go for the bones. The bones. Here you the bones in the pelvic X-ray. You know, like the pelvis is composed of these 5 bones, which include that pubic sacrum, acetabulum, femoral heads, iliac crest, and vertebral lumbar vertebrae. All these bones you have to look at separately. Here you can see all the bone what we have drawn there: ischium, pubic, then femoral head, acetabulum, sacrum. All this you can see here. See, all the bones you have to draw separately. You go through the margin and separately. Is there any discontinuity? Is it? And also you have to compare with the other side like that. Yes. So this way you have to. Otherwise, sometimes you may miss sometimes and rame fracture, small fracture may miss. Sometimes you can a normal X-ray, you know, here there will be a like you know, see the green portion. There will be some radiolucency. This is what is called the. This is a normal. This is what is called the teardrop sign. And also you can see that for us and sacrum and sacral foramus. Now coming to the C, that is the cartilages. Cartilages, basically you have to look at the acetabulum socket, and again the cartilage. So the cartilage, that specifically you have to check it, cartilages and joints. So and check for the pubic symphysis, and check the sacroiliac joint, and also check for acetabulum. You have to specifically look at particularly patients with the vertical shearing injury and all. Acetabulum will be getting fractured. See, here you can see the X-ray. This is the pubic symphysis. Here you can see the sacroiliac joints, and here you can see the acetabulum. Acetabulum. Okay. So next one is a D. D is the diameter. You have to look at 3 diameters. One single diameter, and the other one is yes. First diameter is, you know, that the pelvic inlet. Just to draw whether this is a regular diameter and is any disrupted. See all the diameter. Similarly, you have to compare to other obturator foramina on either side. Is it comparable? Is it disrupted? Like that. The extras including the soft tissue, dyes, hematoma, foreign body catheters, etc. Now you will just go through in the soft tissue here. See, this is like a dye in the pelvic cavity, and sometimes you may get the get hematoma in the pelvis, etc. Soft tissues. And see here, this is this seems to be a normal pelvic X-ray, but the exposure is bit not adequate. But overall, there is no finding. And now, yeah, look at here. This is patients with anterior posterior posterior disruption. You can see that the pubic symphysis is disrupted. It's an open book fracture, and also like there is a disruption in the sacroiliac joints. But the bone wise, it is all no other injury, mainly like these are open book fractures. And see here the same this is the same patient X-ray, and after applying a pelvic binder there, but now that the size of the volume of the pelvic cavity is compact. That is the reason why in the primary survey, and while you are managing the primary, you must do or the effect of the pelvic binding. So that is one of the major intervention, a safe intervention that we can do. Here it is another X-ray. Here, see, this is an old age man. He was in a trivial fall. Here you can see some of the fracture. Sorry. You can see a fracture here. That is the superior ramus. So you can see a fracture on the inferior ramus. Here, this is another X-ray which shows that the inferior ramus fracture with and disruption of the sacroiliac joints. See, here you can see that obvious inferior ramus fracture with the pubic disruption of the pubic symphysis. Here also, in fact, this case is like this man is jumped from the second floor of the building. And here you see like there is a disruption of the pubic symphysis, fractures of inferior and superior ramus here, and also you can see the acetabulum. So there is like the floor of the acetabulum. And this kind of fractures will cause up to 2 liters of blood loss in the pelvis. Here, this is what you can see here. This is, you can see the urethra here. There is a urethrogram. There is a urethrogram, and here you see here there is a leak of the dye because of the urethral injury. Yes, this is a contrast extravasation at the urethral level. Here, this is again another contrast study, an cystourethrogram, and here you can see the bladder. All the dye is exactly confined to the bladder, but see, it is not exactly the same shape of the normal bladder. Or this area, it is a different shape. This is intraperitoneal bleed, and there is a pelvic pack was given here. That is the reason why the bladder is distorted. Along with that, other injuries are there, like pubic symphysis injury, etc. So I am just focusing this to show you that how the extras like. Yes, this is the finding here. And here, when compared with the previous X-ray, here you see like that dye is extravasated in the retroperitoneal space. This is because of a retroperitoneal hemorrhage and then a bladder fracture into the retroperitoneal space. Yes. Here, see that dye is extravasated intra-abdominally extensively. Maybe it is an intraperitoneal bladder rupture with the dye leakage into the intraperitoneum. So these are the few thoughts from my side, and thank you for your patient listening, and we can go for the discussion or if you want.
If anyone has any questions, please post them on the chat box so that Dr. Venu will be able to answer the questions. Dr. Srinath was moved into attendee section. So let me just join him back, sir.
Okay.
Thank you, Dr. Venu. It was a pleasure for listening your talk as usual, and I hope all the residents who are listened to it, it was a pleasure for them also.
Thank you
Any
so much.
questions?
Yeah, there is a question like, can aortic dissection be identified on X-rays?
You cannot confirm, but you can start your thinking. Suppose that you see like the mediastinal widening following a trauma. Particularly, everything is a clinical correlation. Suppose you are patient with a mechanism injury, particularly a patient with a fracture. Usually, the clinical scenario, what will happen? Suppose someone with a scapula fracture. Fracture, first rib, and sternal fracture. If these three things are there, we should have a high index of suspicion. This patient may likely going to go for a great vessel injury. And if that particular patient, if having a widened mediastinum in the X-ray chest, definitely our thought should be there will be a mediastinal. So very often, routine clinical practice. Suppose someone with a scapular fracture. Suppose you're sending for like consultation. People may say like, oh, this is only a scapular fracture, nothing to do. But as an emergency physician, our thoughts will be ignited, and we should reserve that patient for in high index of suspicion. Definitely, it is not a confirmation thing. Confirmation as you go for the CT and other CT angio and other things. But your thoughts should be ignited like it is going to be dangerous.
Yeah, one more question is, you told about the pelvic fractures, but what is the initial management that has to be done?
Okay. In the current guideline, when doing that, first the assessment. Previously, when like 10 years ago, when we are teaching you to do a compression distraction and all. Now it is nothing that you can do a gentle compression test if patient is and the patient show this kind of fracture. The immediately ED, the first step in the ED, go for a proper pelvic binder, and we have that commercially available pelvic binders. If this is not available, even a bed sheet more than to serve your purpose. And this itself, I saw the X-ray, even the pelvic binder, how that volume of the pelvis is reduced. The risk of the pelvic fracture is the hemorrhage. Up to 2.5 liter of the blood will pelvis, something is a conceived way. You cannot detect externally. Patient will be in the shock. So as emergency physician, immediate management, give the pelvic binder, definitely parallelly volume resuscitation, at least 1 liter warm saline, and following if the blood and blood products are available, do it.
Okay, we don't have any more open questions.
Okay.
So this recording is will be live on Facebook also. Dr. Venu, you can share the this one link to your residents, everybody, so that whenever they have time, they can view it on the Facebook also.
Okay, sure.
If nothing much, Dr. Venu, you want to close
Yes.
anything? Can you give any
Yeah, no, nothing. So I won't say it is a great initiative. Definitely, the Srinath effect is reflecting in Hyderabad. I'm very happy to see that. The regular, uninterrupted, like call it, without any every week it is happening. Or is it Srinath? It is something very great, and it will be beneficial for everyone.
Thank you, Dr.
And
Venu.
it is covering basics, advanced, that useful for practicing EPs, useful for residents, everyone.
Yeah. Thank you, Venu, Dr. Venu, for this remark. I'm sure we together we have learned how to teach the residents and how to take forward the academics in emergency medicine, how to treat, and your inputs in that disaster, which I can never forget, which happened in Calicut, and which was a pre-COVID time, and you showed the world how emergency physicians can save the patients. Looking nothing into whether it is COVID or non-COVID, rescuing everybody. That's how we emergency physicians are in the front line. And hats off to you. Thanks to the Yashoda management. Thanks to the Yashoda management for giving us an excellent opportunity to showcase what is required in emergency medicine to all the residents across the world. Thank you again.
Okay. Thank you. Thank you so much.
Next week, we have a topic from Dr. Sarvanvel, medical legal aspects in a nutshell for ER physicians. Do come back, and we'll be posting the webinar links and also the recording links on our Telegram channel. Do subscribe. Thank you for joining us.